You're all set, George.
Thank you. Welcome, everybody. I'm George Demiris. I'm the Associate Dean for Research and Innovation at the University of Pennsylvania School of Nursing, and it's my great honor to welcome you to our 7th annual Penn Nursing Innovation Accelerator pitch event with lead support from the Bedford Falls Foundation. We're excited for you all to hear from our 4 finalist teams made up of Penn Nursing and Penn Medicine faculty and clinicians as they pitch their innovation ideas. Before I explain the round of events for this afternoon, I'd like to introduce the Margaret Bond Simon Dean of Nursing at the School of Nursing, the University of Pennsylvania, Dean Antonia Villarruel, who will provide opening.
Hi, George. Thank you. And thanks to all of you for joining us today for the 7th annual Innovation Accelerator pitch event. As many of you know, Penn Nursing is again the #1 ranked school of nursing in the world. And we celebrate the power of nurses every day. But showcasing the innovative spirit of nurses speaks to the reason why we are leaders in our profession and why programs like the Innovation Accelerator are so important. Nurses are uniquely positioned to see the challenges of healthcare and the opportunities. We use our experiences and insights to solve problems and to create more efficient pathways to help new nurses enter into practice. And while nurses have always been innovators, we are just now finding our place and voice in spreading and scaling our work. And the Innovation Accelerator is here to help by providing funding, mentorship, and skills to advance early-stage ideas into projects that impact health and healthcare, and to do so in a way that involves other disciplines. When we look at the past winners of this pitch event, we see a look at the future. One example is VasoWatch, which received funding through the 2021 event. It was co-funded by adjunct professor Stephanie Modry, and today the company is redefining maternal health with their non-invasive digital biomarker that predicts postpartum hemorrhage before delivery, a lifesaver for many. A few months ago, the company was one of 21 life sciences companies selected to receive special matching grants from the Philadelphia Department of Commerce to support further commercialization. I expect to see the exciting projects selected here today to receive funding, blazing their own paths to success and changing life. Penn Nursing's Innovation Accelerator pitch event would not be possible without the help of generous funders. Thank you to former Board of Advisor Carolyn and her husband Thomas Bennett and Andrea Laporte for supporting our general health and healthcare track, and to the Bedford Falls Foundation for supporting our entry into practice track. Thanks also to our keynote speaker, Chief Nursing Officer at St. Joseph Hospital, Anthony Esposito. And thank you to our judges, Bruce Derringer, a member of our Board of Advisors and Chair of the Innovation Committee, Maria White, Darshan Kulkarni, and Danita Henderson. Lastly, I want to thank our live sketch artist, Rachel Acker. Her work brings these projects to life year after year. At Penn Nursing, we believe the future of healthcare and the future of our profession lies with nurses who see the person, the system, and the population with full attention, with fierce compassion, without fear. And you're going to be hearing from many of them today. Thank you again to all of you for being with us and to see the best nurse-led innovations you're going to find. Thanks.
Thank you so much, Dean. The Penn Nursing Innovation Accelerator provides funding to assist with the creation and testing of early-stage solutions that improve health and healthcare. This year, we partnered with our Penn Medicine colleagues as part of the Penn Academic Practice Partnership. I want to thank them for their support in putting this event together. This year, we will have 2 teams who are innovating how to solve for ready-to-practice issues for new nurses, and 3 teams on the general track. Each team will have 6 minutes to pitch their problem and solution to our illustrious panel of judges, and then I will moderate 4 minutes of questions. As the Dean mentioned, our judges this year include Bruce Derringer, founder of BSD Strategic Advisors and retired partner and COO of King Street Capital Management, Maria White, Advanced Senior Lecturer, Department of Biobehavioral Health Sciences here at Penn, Darshan Kulkarni, lawyer and the Emily Whitehead Foundation Board Chair, Darshan Talks podcast host, author, teacher, and keynote speaker, and Denita Henderson, Managing Director of Pennovation Works. Thank you all so much for being here today and providing really valuable feedback to our finalists. While the teams are pitching today, visual artist Rachel Acker from Health Hero will once again be live sketching the presentations, which will be displayed at the end of the event. Once all the teams have pitched, the judges will leave the virtual room to confer. And while that is taking place, Dr. Anthony Esposito will provide the keynote talk. And following Dr. Esposito's talk, we will announce the winners. As I mentioned, we have 2 tracks this year, the Ready to Practice track, supported by Bedford Falls Foundation, and our general track supported by Carolyn and Thomas Bennett and Andrea Laporte. The Ready to Practice track focuses on problems and solutions to assist new nurses in being ready to practice in today's healthcare settings. The general track focuses on problems and solutions not addressed in the other accelerator track areas specific to health and healthcare. The winner or winners of the Ready to Practice track will receive up to $20,000, and the winner of the general track will receive up to $10,000 to help develop and test their innovation. Depending on the project, this year's winners will participate in either the Pennovation Works Accelerator sessions or the Penn Health Tech Huddles. Both offer exclusive opportunities to advance ideas towards real-world implementation with expert guidance. They will receive mentorship from within Penn as well as the greater innovation and entrepreneurship community. I'd like to thank the Bedford Falls Foundation for their lead support of the Penn Nursing Innovation Accelerator program, as well as Carolyn and Thomas Bennett and Andrea Laporte for their continued support of this event. Before we hear the pitches from our finalists, our accelerator winners from 2025 will provide an overview of their work for the past year, what they've accomplished, even though it was such a short time, but it's really impressive. I'd like to introduce David Yu, who will first discuss his work with his project, Inclusion Idea Box. So David, please come on stage.
Good afternoon, everyone. My name is David Yu. I'm a postdoctoral research fellow at Penn Nursing and a nurse practitioner in the medical ICU at Penn Presbyterian Medical Center. Today, I will briefly present my 2025 Innovation Accelerator project on co-designing a professional development program for advanced practice providers, or APPs, at Penn Medicine. APPs here include nurse practitioners, physician assistants or associates, midwives, and nurse anesthetists. Initially, my proposed project, the Inclusion Idea Inbox, focused on promoting psychological safety among underrepresented employees. However, this concept was ultimately not feasible within the current system. So with the guidance from health system senior leadership, I pivoted to focus on improving APP's well-being, an area of great importance. To support this shift, I held several meetings with health system leaders, including the Chief Nurse Executive, Dr. Bellinghoff. Following the senior leadership's approval, I met with the Associate Chief of Advanced Practice, a senior leader who oversees the APP workforce at Penn Medicine, to discuss organizational priorities for this workforce. I then engaged with APP directors from each entity across Penn Medicine. As a result, all 7 APP directors now serve as a collaborative work group, with 2 APP directors taking more active roles in developing detailed processes with me. This new project uses a human-centered design approach, which focuses on developing solutions with end users, APPs in this case, rather than developing for them, ensuring alignment with real-world needs. Despite substantial workforce growth, many APPs report barriers to career development and limited professional support, highlighting the need for a structured, system-level solution. As a result, this project has been prioritized by APP leadership within the health system. This project follows 4 phases of human-centered design and design thinking: empathy, define, ideate, and prototype. These phases involved understanding end users' experiences, clearly defining the problem, generating a range of potential solutions, and developing and testing the feasibility of the intervention. As I spent considerable time establishing the project scope with the health system stakeholders and the Innovation Accelerator team, the project is still in its early stages. So we are currently in the empathy phase. The goal in this phase is to deeply understand the experiences and needs of APP seniors who are defined as those with at least 6 years of APP experience and at least 1 year at Penn Medicine. This subgroup of APPs was specifically recommended by APP directors due to concern about unmet professional development needs. I am currently conducting individual and semi-structured interviews with a target of 30 APP seniors. The interview guide was co-developed with all 7 APP directors to ensure relevance to both frontline experiences as well as system priorities. Following this phase, we will define the core problem and co-develop potential solutions with stakeholders and ultimately prototype a structured program tailored to APP seniors' needs. Thank you very much for listening.
Thank you so much, David. Now I'd like to welcome Dina Bammer with her project Enhance.
Hello, everyone. My name is Heather Gregg, and I'm partnered with Dina Bammer. We are both nursing professional development specialists at the Hospital of the University of Pennsylvania. Dina Bammer is the Director of Nursing Professional Development. In this role, we support nurses with the goal of successful transition from the learning to the professional practice environment. It is a big adjustment for many nurses. But for nurses who experience the world in a way that has been described as neurodivergent, it can be especially challenging and overwhelming. But we have had the privilege of partnering with nurses of diverse learning styles who have shown incredible perseverance and who have been able to thrive. These interactions led us to explore this topic further and develop a toolkit that would support nurses with different learning styles. Next slide, please. Neurodiversity describes the idea that people experience and interact with the world in many different ways. It's an umbrella term that encompasses several conditions that present unique challenges related to learning and functioning in a neurotypical world. Experts estimate that 17 to 20% of the population exhibits some form of neurodivergence. We support over 700 nurses annually, the orientation of over 700 nurses annually with tools and programs to enhance their learning experiences. So if 1 in 5 of the general population is neurodivergent, chances are high that many of these nurses experience learning divergence and could benefit from strategies to support their orientation. Next slide, please. Statistics from the American Nurses Association and the U.S. Bureau of Labor Statistics project a shortage of nearly 1 million nurses by 2030, with 50% of nurses becoming eligible for retirement in the next 10 years. Additionally, 27% of all newly graduated nurses leave the profession before 1 year. All of this creates an economic loss of $1 billion. These workforce shortages impact safe patient care and are associated with increasing patient mortality by as much as 7%. The nursing orientation process, which was designed around neurotypical individuals, is detailed and rigidly standardized. There is immense cognitive load and sensory load, which may not be conducive to neurodivergent learning styles. Supporting neurodivergent nurses would increase staff satisfaction and retention, promote patient safety, decrease burnout, and save organizations costs related to workforce turnover. Also, neurodivergent individuals possess a wealth of gifts and talents, including creativity, loyalty, and productivity. So without solutions to support the challenges of neurodiversity, we will miss the strength of these nurses. Currently, a singular resource to support various needs of neurodivergent nurses during transition to practice does not exist. Next slide, Dina.
And as you'll see, we also followed the same journey as David had aligned with for design thinking for health and human-centered design. We found throughout our process, we spent a lot of time in the exploratory phase as we really wanted to be inclusive of a solution that would really benefit our nursing students, nurses in their transition to practice, as well as preceptors, leaders, and all involved to really support a successful orientation journey and transition to practice. We thought very creatively about the methodical nature in which we would need to operate. And so this process has been iterative with a lot of lessons learned and again, some time intensivity to align between our empathy stage, which was really comprised of environmental scanning in current state. And again, Heather and I very uniquely aligned with our academic partners to be able to be thoughtful of what currently do we hear in practice environments, as well as additional stakeholder interviews from those transition to practice stakeholders and partners such as the UPenn Weingarten Center, who was able to shed some insight as to current interventions that work really well in the student curriculum realm. We've defined the literature review of the problem or the statement of who the population would be, and we wanted to really refine that scope to the transition to practice track as aligned with the foundation scope here. Additionally, we went through and looked for advocacy reviews and industry standards. We really wanted to be thoughtful of outside of healthcare, who is doing this really well and how we can inform our design. And then finally, we also partnered very closely with our research teams here for what a QI IRB would help to design for our future state and prototypes. As we continue to ideate, we really wanted to be thoughtful, and this is the work that we're currently doing in the upcoming 4 weeks to hold a series of 12 focus groups that has opportunity for nursing students, clinical instructors, nursing at all levels, and leaders to be able to help inform and design our interventions. And we wanted to be really thoughtful of how that would look and align for our end users. We also had the opportunity to align with the project mentor who sits on the board of innovation and help align some of those strategies with us, in addition to the support that we received from UPenn Nursing within the health tech huddles, really encouraging the investment of time into those solutions for our upcoming winners. We also thought carefully about the benefits that currently align in system, and what we found throughout the course of our definition and empathy phase, that we did identify some solutions already in place, which we knew there would be some, but a real growth that we found throughout the course of this year in building some of those resources, really matching to our initial need and our empathy phase to define the problem. Currently, we're using the information from our stakeholders and focus groups to help inform the best prototype that will be a solution for our end users moving forward. And that may include templated designs with multimodal opportunities for learners to enhance their learning styles, and that could be physical or virtual components. We anticipate utilizing a website to be able to house a lot of this information, but we know there's so much more to it than that, in addition to apps and physical attenuators. Ultimately, we want this to be a solution that is self-selected and a pace that works for all nurses at their opportunity and environment. And we'll introduce that during orientation to make sure everyone has the opportunity to use this. And finally, we look forward to testing, communicating, and launching our product, assessing, and then really evaluating as well. So we want to make sure access is available for all. We will continue to assess and evaluate, revise, and sustain a solution. So just to give a glimpse of what we think this could look like, the toolkit itself is going to be a combination of assistive technology. That could be inclusive of even just the types of fonts we utilize in our orientation comprehensive materials. And we know so much of the orientation that we do now is experiential. So that is something that we are doing shoulder to shoulder, preceptor aligning directly in care practice in addition to e-learnings. And so we want to think about the comprehension of visual learners, of those that really enhance their opportunity through auditory means. And so from there, we're going to design a hub of multi-sensory opportunities. And finally, we would be remiss if we didn't consider also the opportunity for learning strategies, community, and belonging. Many neurodivergent nurses have already worked and overcome opportunities and styles that help to support them. And so this is an opportunity for us to consider those opportunities and sharing those in forums moving forward. And for example, a 2025 Gallup study revealed that 37% of employed individuals with neurodiversity often do not disclose any of those considerations that would be most helpful, as there's a due fear of stigma and or sensitivity. So we really want to build a solution that aligns not only resources, but to start the dialogue, which is so essential to be able to align resources for support. With our future of Enhance, we're going to start with our entity first of HUP Nursing at the Hospital University of Pennsylvania. And we know that we already do this work very closely with orientation and competency, but we want to continue it with role development to align with well-being, satisfaction, and leadership opportunities. We know that there's a market pathway. So in the first year, we would like to first start small within our institution, which is not so small, but bridging those opportunities to the larger Penn Medicine at opportunities there, as well as our academic partners in various clinical settings, learning different simulation environments, and then bringing this innovation back to resource centers such as the Weingarten Center. Ultimately, we would love to market this as well to transition to practice programs. There could be various vendors and uptake from evidence-based platforms. We also have professional organizations and then other employment opportunities with other healthcare roles. And so we already have opportunities to align in those spaces, and we work closely with them at current state. And ultimately, it's about designing the future for nurses who have so many strengths to bring to the opportunities. And we are excited and uniquely positioned to be able to offer and enhance the resources that we currently have on site. And so we're looking forward to using those networks, our experiential learning, to be able to partner and align in a way that other businesses potentially wouldn't have the opportunity to do so because of the networking that we do have in academic and clinical practice. We're excited for the opportunity to align and happy to share any of our work and references with teams. Thank you.
Thank you so much, Heather and Dina. I'd now like to introduce Gabriela Schiavon-Ganassin and Jordan DeSander-Lung, who will discuss their work on their project LIFT.
Right. Can you hear me, George?
Yeah.
Just
Yeah.
making sure.
Yeah.
All right. Hello, everybody. My name is Gabriela Schiavon-Ganassin. I'm a clinical nurse educator at Penn Presbyterian Hospital, and I'm here on behalf of my team to present our solution, which is the larvae isolation flex treatment, a solution for maggot removal in wound care. So here's the team. So I would like to just present everybody on the team. As someone once said to me, it really takes a village, and this team has been crucial in every single step of the way that we're of what we're able to accomplish so far.
Gabriela, sorry to interrupt. We're looking at your notes. I don't know if you wanted to do the full slide. Oh, perfect. Thank you. Sorry about that.
That better?
Yeah,
All right,
it's
cool.
great.
So LIFT is formed by very strong, willed women and combines basically a frontline clinical staff at Penn Presbyterian and some technical expertise all together with our world-renowned hydrogel research, which is Claudia. So first, I would like to begin by sharing a story of Rosa, which is a patient that was recently saw at the emergency department, and that really illustrates a challenge that clinicians encounters but rarely talk about it. So Rosa was a street vendor that came to our ED department who walked into here once, and she, with what she thought was just a stubborn wound on her ankle. She had been hiding it under a sock for weeks, hoping it would heal, afraid of missing any days of work. When the nurse just removed the sock, the truth became clear. Rosa had maggots in her wounds. She was embarrassed, ashamed, and she was terrified. With no tools, with the tools that we currently have today for that kind of process, there's no quick fix. Just fear, some discomfort, and a lot of time for manual maggot removal. Rosa's story feels like an exception because we don't hear much about something unusual, something rare, but it really isn't. Rosa is one of almost the 240,000 cases that walk into U.S. emergency departments every year with parasitic wound complications. Rosa is not an exception. She's a pattern we've been missing. This isn't a distant problem. It is happening in our own communities. Using a Sentinel data from Philadelphia Emergency Department and getting that extrapolated across the city, we estimated nearly like 2,900 cases every year in Philadelphia alone. Despite this, like parasitic wound infections have no standardized method of removal. Clinicians rely on slow manual extraction of larvae, sometimes taking hours to days and prolonging emergency department stays. The financial burden is substantial. Hospital admissions for these infections can cost between $26,000 to $42,000 per admission per patient, and the consequences can be severe. Each year, roughly, we see 6,000 like amputations that are linked to this kind of infections, and patients usually remains like hospitalized from 24 to 48 hours to ensure the wound is completely cleared. For the patient, that is 2 days of missed work. For the health system, that's 2 days of hospital beds, staff time, and resources, times and costs that could be potentially be avoided with a more efficient solution. And that's when we came in. So basically, to summarize the core problem, there's no standardized method for maggot removal, and creates patient distress, safety concerns, and added strain on the clinical teams, particularly given the stigma surrounding this condition. So our focus with the funds provided is to develop a patient-centered solution that prioritizes safety and provides a more humanized and effective treatment. So here it is, our Lift dressing. Lift is a hybrid dressing that combines hydrogel technology with a biological attractant to draw maggots out of the wound bed into a layer of control and efficient extraction. This is a rapid action dressing with an expected time of complete removal from 6 to 12 hours of resolution of complete maggot removal, that allows for same-day ED visit discharge. It promotes complete maggot removal, meaning that it will reduce the risk of larvae remaining in the wound, causing further infections. And for patient, it takes away the stress and the pain that offers like a better and dignified treatment. For the clinicians, like for the nurses and any other clinicians that is dealing with that, offers a safer, effective approach that will reduce the need for the prolonged manual extraction and the extended hospital stays. So initially, the plan was a little bit different, was to have like bench testing results already ready to be disseminated here by this April. But as you hear from anyone that was in the innovation program before, it takes always a little bit longer than you initially planned. Although we were not still ready for bench testing right now, the Innovation Accelerator so far allow us to do a lot in this short period of time. So we were able to get connected with the world-renowned hydrogel bioengineer research, get access to the Lobo lab. We started developing our early stage prototype. We were connected with an advisor that guide us through the business side of the innovation. We were able to network with the nursing lab that is very needed for our preclinicals that are coming soon. We were able, with the same networking, led us to apply for the Penn Health Tech for further develop our concept and the business model that we really needed. And sometimes nurses don't have that much as well. And also understanding the path that we need to just get to our innovation into the market. So, besides that, we were able to also complete multiple stakeholder interviews in this time frame, nationally and internationally, to better understand the needs and further develop our prototype concept, and pivoted from the vet industry that we initially thought we could do to as well to a human only now. So what it was completed so far, we're still in the process of finalizing the formulation for the attractant, because we're still testing concentrations, responses across different species of flies, effectiveness of recruitment, temporal dynamics of this migration, and hopefully very soon we're moving into bench testing phase. So for next steps, our currently milestone focus is on the feasibility overall of the dressing with the concentrations and validating its mechanisms and by finalizing the attractant component overall. Because with the bench testing, we're gonna be able to just like position us in for like expanded funding. So currently we are a semi-finalist of the Penn Health Tech Accelerator program, and hopefully we will be able to secure like funding for the bench testing that we will need. As you will see in this next slide, we'll still have a long way to go until we hit the commercial phase. It's really how Marion used to say, it's a marathon, not a sprint. We're still in the discovery phase, leading us to the preclinical evaluation right now. But it's a long ways that we have to go to get this innovation into market. So on behalf of all my team, we would like to thank you, the Nursing Innovation Accelerator team, especially Marion, for believing in our idea as supporting us addressing this topic that is often considered a taboo and not very pleasant to discuss, even though it affects far more people than we really openly acknowledge. The connections that were made with key professionals to bring this project to where it stands today, and to give us the validation needed to move forward, like allowing us to bring this issue into the light and to treat it with the seriousness and the dignity it really deserves. Thank you.
Thank you so much. And then finally, for the 2025 cohort, I would like to call Shoshana Aronovich and Eleanor Turi with their project Virtual Wound Care.
Hello, my name is Eleanor, and I'm here with my partner, Shoshi Aronowitz. We're excited to update you today about our innovation of tele-wound care consultations. There are about 5.3 million people in the United States diagnosed with opioid use disorder. And if you use drugs, you'll most likely experience a wound at some point due to skin and soft tissue infections, chronic homelessness that's associated with weather and trauma-related wounds, or being exposed to contaminants in the drug supply known to cause wounds, like xylazine, which is currently in about 40% of the Philadelphia drug supply. Yet, half of people who use drugs avoid hospital care due to fear of stigma, discrimination, and withdrawal. We need solutions to increase access to specialized wound care in community settings. Our solution is not a product or device, but an innovation in the way we deliver care. With our innovation, we brought specialty wound care to the community, a trusted source of care among people who use drugs through tele-wound care consultations. Specifically, our solution begins with a community provider who identifies a patient need for specialized wound care. They then initiate a teleconsult with a remote wound care nurse. Then the community partner delivers patient-centered wound care together with the wound care nurse, who advises on things like antibiotics, x-rays, or the need for hospitalization. We use existing conferencing platforms such as Google to conduct these consultations.
So over the last year, we have implemented our innovation at Courage Medicine, a nonprofit small healthcare organization based in Philadelphia that offers opioid use disorder treatment, sexual health services, counseling, HIV prevention, and many other services to people who use drugs. And then in the last 2 weeks, we have partnered with the Everywhere Project, which is another harm reduction organization in Philly, to expand our project. They offer food, clothing, harm reduction supplies, and wound care to the community in a very low barrier, accessible model. The wound care is delivered by registered nurses, harm reduction professionals, and medical students in a tent on the sidewalk in Kensington. One of the expert nurses is taking a step back from being on site every week, and our telehealth model will fill the gaps on the weeks they're not there in case that the on-site staff would like an expert consultation for patient care. So far, we were able to successfully launch our innovation as planned at Courage Medicine at multiple sites in multiple days. This took a few meetings with our community partner, coordinating busy schedules and outlining a good protocol for care. This partner, they're all busy clinicians, but they were really excited and interested in our model. And we really learned a lot in our first year trialing the intervention. There's been limited patient demand, actually. We hypothesize that this is likely because of the drug supply. Xylazine, the contaminant that Eleanor was mentioning earlier, which is known to cause wounds, actually no longer predominates the street opioid supply anymore. A new sedative, medetomidine, is present in most drug supply samples now, and it's possible that this contaminant doesn't cause wounds the same way that xylazine did. We also hypothesized that our low patient demand could have been because our first site at Courage Medicine was at a location in Northeast Philadelphia that did not serve as highly acute of patients as their Kensington location. So we've also learned better how to support clinicians who are very new to wound care and have competing priorities. Having to stop what they're doing, open their laptops or phones, and call the wound care provider can be a lot of steps for someone who's really busy in clinic. So Eleanor has gone in person a few times to address questions and kind of work through issues with the team, hoping to continue to support them in implementing our model.
We also trialed some implementation strategies to address the challenges we were experiencing with low patient volume. To recruit more patients, we created this wound care myths and facts poster for the waiting rooms at Courage. And we also conducted a second in-person refresher training and answered questions from staff members. We also expanded to a new site at Courage in Kensington that likely had more patients. And then we're also scaling to the Everywhere project where there are more people, more staff at the site. So that addresses the problem of having to be on the computer and doing wound care at the same time. And the Everywhere project also may have a larger patient population that could help with demand. The Penn Nursing Innovation Accelerator has been instrumental in our progress. We spoke to an expert, Rich Panola, who's a wound care expert, who gave us some advice on how to figure out billing for wound care at Courage. He also provided some key advice on potential pitfalls and sources of strain in our model, like relying solely on Medicaid, which has limited reimbursement funds. We also attended the Penn Health Tech Innovation meetings, which provided new perspectives on how to view our project, not as research, which is how Shoshi and I are trained, but as a product that can be scaled, adapted, and trialed in new ways. And then we also learned a lot from our regular meetings with Marion, who gave expert advice on how to implement innovations with busy nurses who may not want to do the thing you're trying to get them to do. So overall, as we move forward, we're looking forward to continue to impact our community in novel ways and are grateful for the support of the Innovation Accelerator. Thanks so much.
Thank you so much. Thank you to all our presenters from the 2025 cohort and also giving us updates on their projects, the impressive ideas and projects that they're pursuing. Now we're excited to begin our pitch event. As a reminder, the teams will have 6 minutes to pitch, and I'm using a timer, and 4 minutes of feedback from our judges. Judges, if you can please come on stage. And I would like to bring up our first pitch presenter in the Ready to Practice track, Ellen Winkle.
Thank you. Oh. Okay. Okay. Good afternoon, everyone. My name is Ellen Winkle, and I'm from Penn Medicine, Princeton, and I'm here to share a nurse-led solution to improve practice readiness and prevent burnout. Imagine several patients arrive at the emergency department at the same time, each with completely different conditions. There's a broken leg, a laceration to the eye, a migraine, and someone has flu-like symptoms. And we prescribe the same treatment to all of them. Well, that would be unacceptable. But that is exactly how we approach nurse well-being. We offer the same generalized wellness resources to all employees and expect them to impact complex, sometimes unit-specific wellness needs. The issue isn't a lack of resources, it's that they're disconnected from the realities of nursing practice and their impact on well-being. So we asked, What if we treated nurse well-being the same way we treat patients? And that led us to unit-based nurse well-being care plans. Nurse well-being is under strain, driven by high acuity, workplace violence, turnover, documentation burden, and the demands of shift work. But one of the greatest risks happens early in practice. Nearly 1 in 5 new nurses leaves within the first year, and up to 1/3 within 2 years, largely due to transition shock and a lack of effective support. And that turnover comes at a cost of about $60,000 per nurse. We need to support practice readiness and retention by designing environments that support well-being from the start. Our approach takes the care plan framework nurses use every day and applies it to their well-being. I start by anonymously surveying each unit's nurses to better understand their specific wellness needs and how they prefer to receive support. I then analyze the data to identify the unit's top priorities and match them with evidence-based interventions and existing resources. And then I partner with the staff to implement a plan aligned with that unit's unique workflow and culture. And here's why this model works where generic approaches fail. Nurses' needs vary significantly across units. For example, our OR nurses told us that they were most concerned with the physical demands of standing all day and preferred independent interventions in app-based support, while our nurses from the eating disorders unit prioritized their emotional well-being and preferred team-based interventions. Generic wellness programming doesn't work. Our model makes support relevant, accessible, and embeds it directly into their practice environments. The one-size-fits-all approach to well-being is contributing to the turnover rates of new-to-practice and experienced nurses. Traditional approaches create low engagement, time barriers, and expect many interventions to be accessed outside of working hours. Our care plans bring customized, nurse-informed support directly into the unit, driving shared ownership and targeted interventions. This shifts well-being from an individual burden to an organizational responsibility. Nurses aren't asked to choose between self-care and patient care. We're creating environments where nurses can have both, leading to better outcomes for everyone. We used a $25,000 seed grant from Princeton House Foundation to pilot this model across 7 units. The money funded unit-specific programming and champion training. The grant, which we fully expended, helped us to demonstrate the impact of our model. Following the pilot, nurses reported reductions in emotional exhaustion, burnout, and even a 100% reduction in intent to leave. At $60,000 a nurse, that's a substantial ROI. The Accelerator grant allows us to scale the impact to reach the rest of Princeton Health, which is nearly 1,000 nurses, including our RN residency program, and further expansion across the health system. The model is built for sustainability because it's already embedded in how we operate. It's led by my dedicated role as the clinician well-being coordinator, reinforced through our strategic plan and shared governance, and maintained through shared ownership at the unit level. Because it's integrated into daily workflows and leverages resources we already have, it doesn't add burden, it becomes part of the way we work. In the near term, our focus is integrating care plans directly into RN residency and onboarding programs because we know early turnover and practice readiness is one of our biggest risks. As we scale, we want to incorporate AI to accelerate and streamline data analysis and integrate with mobile devices to improve delivery of content and communication. That will allow us to expand efficiently across more units and ultimately across the health system without increasing operational burden. We're requesting $20,000 to scale the model. A portion goes to help us build a better data infrastructure and reporting process. We'll also need funding to support the AI and tech integration goals we have. And the largest portion is dedicated to training, education, and customized programming on purpose. We don't intend for this care delivery model to be driven by one person. To continue scaling, we'll need trained leaders and unit-based champions everywhere who can implement and sustain their care plans locally. And this is our clinician well-being team behind the care model. Collectively, we bring clinical, operational, and well-being expertise, and we have the support of our Director of Professional Practice, Innovation, and Research, and our CNO. And with that, I say thank you, and I will stop sharing.
Thank you so much. And it was exactly 6 minutes, so that's perfect.
Woo!
Now we have 4 minutes for our judges to ask questions.
I have a very simple question. What kind of support have you given so far? Could you give examples of that?
Absolutely. So, for example, in OR where they were really strained with standing all day, we brought in somebody who could do small workspace yoga that doesn't involve mats. We took that same concept and we translated it for those who spend more time charting to do some desk yoga. So really bringing on-site programming in for them in whatever is meaningful for them.
And it's always wellness-based, not like medicine-based, for example.
Correct. We look at wellness from 6 different domains of well-being, and we interview them and survey them around all 6 domains. So it may not just always be physical wellness. It could be spiritual, it could be professional, intellectual, etc.
I have one more question, which is how do you handle the AI component of this and the confidentiality elements that might have to be incorporated with the AI?
Right now, we aren't using AI at all. That's part of the goal for growing this. And the surveys are completely anonymous, so there is nothing in terms of confidentiality. We really just want them to tell us very openly what it is they need without fear of it coming back to them.
Ellen and team, thank you for that presentation. What do you anticipate the greatest challenge would be in the more wide-scale implementation of this?
I think bringing on the tech integration piece, because we are so manual right now. Building that out, I think, is a critical turning point for the program growing, but something we haven't even begun to start yet.
Thank you.
Thank you.
Great presentation.
Thank you.
So I'm just wondering, have you given any thought to who the payer would be and what your revenue model would look like for this product, for this program?
No, haven't put much into that right now. We've been really doing this with existing resources and, as I said, funding it with grant money at this point, really just trying to prove the concept that this model works.
Maybe as a follow-up to that, is the idea that you would train other health systems to implement the model? Is that the idea? And
Yep. In my big picture thinking, at some point, this becomes a program where we can train people to understand the wellness needs and how to best survey and find the needs of the nurses, create the care plans, and then implement them at their organization. Because your resources at each organization will be different. So we need people who live and breathe that organization's work to understand what they have or what they don't have and need to go get.
And then how do you think about it? It seems like the model is more structured towards a unit as opposed to individuals within the unit. I'm just curious, how do you think about the distribution of different issues across individuals versus the unit as a whole?
Yeah. There, of course, I was just looking at another care plan this week for a unit, and there are always a few outliers who very clearly requested specific wellness needs that did not end up being in the top 3 for the whole unit. What we always put out there is that for anyone who has those individual needs, because I am a clinician well-being coordinator, I'm a health coach by nature, they can always reach out to me one-on-one if they have specific wellness needs that aren't being met by the care plan, and I'm more than happy to work with them to get them connected to the existing resources. What we find is that in most cases, especially thinking of Penn, we have an exhaustive amount of wellness resources available to our staff. The biggest challenge is connecting the staff with those resources. So if nothing else, somebody in our program, and we would train others to do the same, almost become ambassadors that connect staff with the needs and the resources that are available so that they get plugged in and get the help they want.
How much does this assume sort of the supervision and resourcing that your health system has versus, like, do other health systems have similar support functions and people who could spearhead this kind of initiative and have the resources to build that out?
What I can tell you is that a chief wellness officer or a clinician well-being coordinator type role is growing in demand across the country because we are putting such a lens on clinician and nurse well-being. And more what they're finding is they need somebody who can drive programming specific to those priorities for those clinicians. So I do see this being something
that is taking off around the country. And I see that role being the person who sort of drives the ship for this care model at those organizations.
Do you see this when you scale this? Do you first see it scaling across Penn, across the various departments, or do you see it as nursing based and then focusing across nursing across the country, if you will?
I think, just thinking from an organizational standpoint, it's been easiest for us to organize it through one department. So nursing department through Princeton. And I think where it extends beyond that, whether it continues up nursing across Penn or across other clinical teams, I think sort of depends on the size of your organization. Princeton's one of the smaller ones in the Penn system, and it might be easier to expand it to other clinical teams at our organization than it might be at one of, say, HUP. At HUP, it might be easier to drive it straight up nursing, where we already have access to the same teams, and then take off from there. We do realize the value of looking at all clinical teams, though, because the work we do is obviously so interdisciplinary.
Thank you so much. Unfortunately, we're at the 4-minute mark. Ellen, thank you so much.
Thank you.
And now next up in the Ready to Practice track, I'd like to invite Florence Vanek and Annalise Wood.
George, where is the share screen?
It should be down on the lower part. Yeah.
I got it. All right.
Perfect.
Annalise?
Great. Thanks so much, George. Thanks, Flory. Good afternoon, everybody. I'm Annalise Pfeiffer. I'm a nursing professional development specialist here at Penn Medicine. And I'm here with my co-creator, Flory Vanek, and we're here to share Core Insight, a solution focused on making workforce strain visible before it becomes burnout.
Hi, I'm Flory Vanek. I'm the Associate Chief Nursing Officer for Quality, Safety, and Practice here at Penn Medicine. Let me start with an example that reflects what nurse managers are navigating every day. Nurse managers carry enormous responsibility. Many oversee unit operations for more than 100 multidisciplinary team members. They want to support their teams, be present, and notice early when someone is struggling. But their day is consumed by staffing gaps, call-outs, overtime, and constant operational demands. The signals are there in scheduling patterns, sick calls, safety events, electronic health record data, and engagement surveys. But they're fragmented across multiple systems. So, by the time a nurse manager realizes someone is burning out, it's often too late. This creates a cycle. Nurses leave, teams destabilize, and managers are left feeling like they failed despite doing everything that they could. And this isn't a small problem. Most nurse managers today oversee very large teams. According to a recent American Organization for Nurse Leaders white paper, in high turnover units, 80% of nurse managers oversee more than 50 staff and 25% more than 100. At the same time, turnover can cost upwards of $85,000 per nurse and tends to be the highest in medical surgical units, where new to practice nurses are the most concentrated. Managers are expected to support well-being, retention, and safe practice, but their visibility into staff strain is limited. They're left piecing together information across multiple systems with no clear way to detect cumulative stress early. The impact is profound. Managers spend most of their time reacting, plugging staffing gaps and managing operations instead of leading and supporting their teams. That shift shows up in burnout, turnover, and decreased retention, especially for new to practice nurses. This is often attributed to readiness, but it is more accurately reflected as a gap in how our systems support them. When early warning signs are invisible, we're left responding to crisis instead of preventing it. This leads us to our solution, Core Insight. Core Insight is a real-time predictive insight tool that brings together operational, clinical, outcomes, and lived experience data to surface early signs of workforce strain without adding to a nurse manager's workload. What this looks like in practice. A nurse manager opens the dashboard and sees a simple signal. One of her nurses has a rising empathy index. That signal is powered by patterns that we already have. Recent high acuity assignments, extra shifts, floating, and no recent time off. Individually, none of these would raise a flag, but together, over time, they indicate increasing strain. Core Insight makes that visible early, before burnout and before turnover. So instead of reacting late, the manager can act in the moment, adjust assignments, check in, offer support, no new documentation, no extra steps, just clearer insight. That is the shift from fragmented data and delayed awareness to early actionable visibility that helps retain nurses and stabilize teams. Most workforce platforms focus on productivity or scheduling. Engagement tools measure burnout after the fact. Core Insight sits between them, using operational and clinical data in real time to detect early strain and support proactive leadership. It's designed specifically for nurse managers, not human resources, not finance, and it uses data that we already have available without any added documentation or work for the nurse manager. Our primary customers are health systems and hospitals investing in workforce stability, with chief nursing officers and nursing leaders as key decision makers. The primary users are nurse managers, and the impacted population is clinical nurses, particularly those in their first 2 years of practice. Within Penn Medicine alone, that's more than 10,000 nurses. Nationally, there are 4.7 million registered nurses, and nearly 60% of those work in hospitals. This is a widespread and urgent workforce challenge, and one that directly impacts safety, quality, and retention. Annalise, you're on mute, sorry.
So we're here requesting $20,000 to support Core Insight. This funding will support usability testing, governance and privacy review, analytic validation, user experience and interface design, and data and analytics engineering. We've already completed phase 1 through the Johnson & Johnson Nurse Innovation Fellowship, using a human-centered design approach to prototype and co-create Core Insight with nurse leaders, managers, and clinical nurses. With this funding, we will move into phase 2, continuing software build and app development. In phase 3, our 2 nurse managers, part of our team, will pilot Core Insight on their units and iterate with us in real time. Then in phase 4, we will scale to 7 additional medical surgical units, 1 in each of the Penn Medicine acute care hospitals. Over the year, we'll aim to scale to more than 70 nurse managers, reaching over 2,600 nurses and iterating alongside them. Even a modest reduction in turnover, for example, from 14.5 to 12.5%, could keep 140 nurses in their medical surgical units, saving us at Penn Medicine roughly $20 million in cost. This here's the team moving Core Insight forward, led by Flory and myself, with the support of Chief Nurse Executive Jim Ballinghoff and a multi-interdisciplinary group of nurse leaders, managers, clinical nurses, and subject matter experts. The future of nursing support must be proactive and not reactive. When we connect existing data and turn it into insight, we give leaders the ability to see earlier and act sooner. At Core Insight, we know that retention, well-being, and safety starts with visibility. Thank you.
Thank you very much. And now I'm going to ask the judges for any questions for the next 4 minutes.
Bruce, are you going? Or
Yeah, I have a question. Can you talk a little bit more about the data piece of it and the integration of the data? It seems like it would take a fair bit of effort to integrate the sources of data. And is any new data creation required? So maybe you could speak on that, please.
Sure. So first, I think to answer the second part of your question, no new data creation is required. The nurse manager is not going to have to look at any additional dashboards. The whole, right now, what they do and what we spend our time as a nurse manager doing is looking at several different fragmented dashboards. And then we are expected to pull that information together and create this picture to talk about our unit or the specific nurses that we have part of our teams. So we have HR dashboards, we have dashboards with EHR data. I have other additional dashboards with clinical data, but this would make us into one cohesive place, like a one-stop shop, and help us create a better picture about the individual nurses, but then also all of the nurses collectively on our units.
I have an easy question. How have you validated the tools that are going to indicate nurse burnout? Because that seems like a very complex problem. So how do you know that those are the ones that matter?
I'm sorry, go ahead, Annalise.
No, go ahead. Sorry.
There is a lot of research available that connects different pieces of the nursing workload to nursing burnout and nursing turnover. A lot of that research actually comes out of the Penn School of Nursing with Dr. Linda Aiken. So there are pieces that we know. We also have been working with a data analyst. We've been working with a chief nursing informatics officer at what's available out there in different packages that are isolated that will indicate whether or not a staff member might be at risk for burnout or need some attention. I do agree with you. I think that we would need to pull everything together and work on refining what that output is. And I think that's a big piece of the work that's ahead of us. But I do think that it's possible. And I think that there's a lot of research out there that grounds the approach that we're taking.
It's great. Great presentation. How do you factor in various externalities that may not show up in like the HR data or the records that you have? And how do you account for like the individualization and how it affects the overall output of the data?
Yeah, that's a great question. I think we like to think about that as version 2.0. Where nurses will potentially be able to give feedback to the data set about how they felt about their shift. Yes, maybe the EHR, what the data that we are collecting 100% of the time, all the time, maybe is not reflective of how they are feeling. So we are looking to second layer, develop a way for them to give us impact on their experience of the day or the shift or the moment.
Thank you for that presentation. So as far as implementation and kind of maybe like next steps and sustainability of this work, do you anticipate a uniformed algorithm on how nurse leaders should be addressing these key identifiers that you mentioned in the components of anticipating nurse burnout?
Yes, so we see our tool as not just giving you an alert, hey, this person needs some assistance. It would give you the drivers behind why that person needs assistance and then give you tips or tools for what a tailored intervention might look like for that individual nurse, depending on what the drivers of their potential risk for burnout are.
Thank you.
Do you guys have a working prototype of the app itself yet, or that's something that has to be developed? And then is that as sort of a desktop app as opposed to I assume a phone app? And I'm also curious in terms of scaling this out to other health systems, how consistent is the universe of data sources that you want to integrate here?
And if you could answer that in 25 seconds, go ahead.
Sure, we do have a low fidelity prototype that we have used for iterating with our team. Yes, it built in PowerPoint, but we have been testing it just for design look and the data streams. And then to answer your second question, yes, we would design it with Epic. As you know, most hospitals use Epic integration and the signal data that's already from there, in addition to Kronos or UKG. So in thinking about scalability outside Penn Medicine, I think that is a possibility.
Thank you both so much. We need to move on to the next track, which is a general track. And the first pitch presenter in that track is Tammy Doyle. Let me see if Tammy can come to the stage. It looks like maybe we have some technical difficulties with Tammy's pitch, so maybe we'll move on to the next one if the next presenters are ready, and then get back to Tammy afterwards. Oh, there she is. Okay, never mind.
Hi, can you hear me?
Yes.
Hi, good afternoon. My name is Tammy, and I'm a nurse lactation consultant at HUP. And today I'm here introducing My Milk, a continuous public health technology bridge designed to provide expert support from the first trimester through the first 6 weeks of life. I want you to meet Jordan. I met her at the bedside at HUP. She was exhausted, tearful, and on the verge of giving up. But Jordan's struggle didn't start at the bedside. It started months earlier. Jordan has PCOS, a common condition that we know clinically can delay milk production, but no one flagged that for her prenatally. She entered motherhood with a hidden physiological hurdle and zero specialized education on how to manage it. When she got home, the support cliff hit. At 3 a.m., when her baby wouldn't settle and her milk hadn't come in, she didn't just feel tired, she felt like a failure. Had we identified Jordan's risk factors in the first trimester, we could have provided targeted education and clinical plan. She would have known the why behind her struggle, and she'd be less anxious and have the tools to persevere. My Milk app helps patients like Jordan never have to wonder why their bodies aren't following the standard script, so they have a plan before they have a crisis. Jordan's story is the Philadelphia story. Our Black and brown mothers face a mortality rate 2.5 times higher than the national average. While 85% initiate breastfeeding, 60% stopped earlier than intended because expert guidance vanishes the moment they leave the hospital. To those outside of medicine, for our NICU infants, human milk is a biological shield. It reduces the risk of necrotizing colitis, a complication that affects 10% of preterm babies by a staggering 75%. Beyond the NICU, breastfeeding is our most effective tool for long-term health equity. It's clinically proven to reduce this incidence of SIDS by 50% and significantly lowers the lifetime risk of asthma, severe allergies, and obesity. For the mother, it's primary defense against hemorrhage, breast cancer, and type 2 diabetes. This failure costs our economy $3 billion annually and drives avoidable ER visits for dehydration and jaundice right here at HUP and CHOP. By protecting the 6-hour vital window, we aren't just supporting a mom, we're protecting a biological intervention that scales from the bedside to the community. My Milk is a public health technology tool that creates a continuous bridge beginning prenatally with risk detection surveys to provide targeted education affirmations before delivery in over 12 languages. In the hospital, it provides hands-free voice logic for real-time tracking, including the vital NICU 6-hour expression window. Post-discharge, it follows the family home for 6 weeks with smart triage flags. We are moving from a reactive model to a predictive and preventative system. Our SMART goal within 90 days of prototype completion, we will pilot My Milk at HUP with 30 families, achieving a 10% reduction in nursing documentation time and a 30% increase in patient confidence, which confidence is one of the biggest predictors in breastfeeding success. When we look at the landscape, it's clear that commercial apps are built for lifestyle tracking. My Milk app is the only solution designed as a professional clinical bridge. We aren't just an app, we're an integrated system that includes prenatal risk surveying, NICU-specific logic, inpatient electric health record sync, hands-free logic, critical post-discharge flagging, and a direct PDF handover for pediatrician after discharge. We are replacing a static paper packet with a dynamic equity-focused system that connects the hospital, the home, and the community. Our customers are health systems like Penn Medicine that are prioritizing value-based care. In our system alone, we serve 15,000 families annually. My Milk uses a B2B model, business-to-business model. We charge the system, not the family, ensuring zero barriers to equity. The ROI is immediate. By preventing just 2 neonatal readmissions for dehydration or jaundice or 2 cases of NEC, this app pays for itself for the entire year. We are a cost avoidance tool for the hospital and a life-saving tool for the city. We are requesting $10,000 for a 90-day pilot. These funds cover our technical costs and equity-focused tablet loaner program. To succeed, we need executive nursing sponsorship and 20 hours of IT support in our Epic Sandbag validation. Following my technical consultation on Monday, we have confirmed the path forward and we have the clinical skills and the tech buy-in. Sustainability is built into our design. Penn Medicine is already deeply invested in maternal health equity. My Milk app provides the digital infrastructure to meet these goals. By proving we recover vital nursing hours during the 90-day pilot, My Milk moves from a project to a permanent clinical efficiency tool. We're building a standard of care protocol that the health system sustains because it saves time, money, and lives. My Milk is built on a scalable architecture designed to grow with the health system. Within 1 year, we scale across the entire Penn Medicine network. My Milk app isn't just an app, it's the first step toward a universal digital assistant that ensures no patient, especially our highest risk mothers, ever have to navigate a health care transition alone. I'm the leading project for this, and we're joined by Dr. Diane Spatz, who's a global leader in lactation research, whose evidence-based models are the foundation of logic, and Mary Ross brings her deep expertise as a BSN nurse to ensure that the app fits seamlessly into the real-world nursing workflow at HUP. And together with our HUP IT tech lead, we have the clinical authority, the research backing, and the technical buy-in to turn this vision into a reality. Health equity is found in the quiet moments at 3 a.m. when a mother feels capable and supported. Remember, My Milk is predictive, integrated, and equitable. We are ensuring when Jordan walks out the HUP door, she isn't walking off a cliff. She's walking on a bridge that we built together. Thank you.
Thank you so much. Again, we have 4 minutes for the judges to ask questions.
I want to turn back on. Hello. I'm here for questions, and I want to stop sharing here. There we go. Okay.
Tammy, thank you for that presentation.
Sure.
I do have a question. You mentioned about integration with EHR and, predictive analytics. So is this essentially almost like a chatbot that mothers would be engaging with? And then on that note, is there a way to expand it to touch base with clinicians if needed?
Yes, so there is a voice capability on it, and there's a tracker built into it. So if the patients get this app prenatally, it's used in the hospital, and they can also use it in the community. When they're in the hospital, they can use the tracker. If it's 3, 4 a.m., they can say, ask the app, can you please track that my baby had a pee and poop? Can you track that I did a feeding? At the end of the shift, the nurses come in. The nurses will just need to reconcile because it will go to Epic chart, and they'll just need to reconcile, and then it will be documented. So that is more accurate as opposed to really tired parents, with their little crinkly piece of paper trying to remember what happened overnight.
Thank you.
Mm-hmm.
I'm curious, is it meant for educational purposes, or is it meant for, it wasn't clear if it was meant for that or it's meant for identifying problems, or both?
Thank you for asking that, because I'm sorry to interrupt. I realized that as I was talking, I talked a lot more about the reason why we need it and what we're going to do with it as opposed to what it does. But the app, when families find out that they're pregnant, the sooner they get education, evidence shows they're more likely to breastfeed. They can put in their estimated delivery date, and then they'll get weekly affirmations and education until they deliver. And then when they're in the hospital, they can use the tracker to keep track of pees and poops, but also there's different videos. So, and again, when it comes to 2 or 3 in the morning, they can just click on how to latch the baby. How do I know my baby's getting enough? We plan on putting a video on of the lactation team, because clearly we're not there 24/7, and we want to be able to give them anticipatory guidance of what to expect, because infant feeding behavior sometimes can be confusing for parents, thinking they need to be supplemented or get something else. So this video is a way that they'll be able to get anticipatory guidance to prevent that. And then after discharge, it's no longer shared with the electric health record, but what the parents can do is continue to keep the tracker, and they can print it out to bring it to their pediatrician. But it will flag, for example, if there's not enough pees or poops, there'll be a flag to say, this is an issue, you should call the pediatrician, or if there's anything else going on, there's just a clinical flag to let patients know that they should contact their provider. So it's prenatal, in hospital, and after. I have a QR code that people can play around. I built the app using an app building program, and again, just the 6 minutes didn't allow me the time to show all of it, but I could pull up a video if anybody wants to see it.
And again, great job. But can you tell me again how much traction you have or what stage you're in as far as rolling it out or?
So that the app is built, but what we want to do with some of the money is to make some good professional videos to put in for the parents' education videos. And we met with the tech team, we met with Epic and the tech team at Penn, and what we'd like to do is fine tune, like I said, the education videos and do a pilot of 30 families.
Great. Thank you so much. I think we're running out of time for the Q&A part. Thank you again. And
Sure.
Next up in the general track, I would like to call Abigail Wilpers.
Thank you, George. I'm going to share my screen. Okay. Is that all looking okay?
Yes.
Great. All right. Thanks, George. So I'm grateful for the opportunity to present the perinatal window on behalf of my team. Lori and her partner go in for a routine anatomy scan, excited to see the first images of their expected baby. And instead, they learn that something is wrong with the baby's spine. Within days, Lori is meeting with specialists and told that she has 3 options: continue the pregnancy and plan for surgery after birth, pursue fetal surgery during pregnancy, or end the pregnancy. Lori must try to understand what this diagnosis means, make a decision, and figure out where that care can even happen, all within a matter of weeks. This is a moment of crisis. And whether Lori is able to receive the care she needs will be shaped by what happens during this perinatal window. In other words, the period following prenatal diagnosis, when care plans, referrals, and delivery decisions are established. During the same window, Lori's provider is facing that same crisis. They're responsible for counseling her while trying to piece together what is actually possible, navigating evolving clinical information, rapidly shifting policies, and uneven access to care. Am I even allowed to talk about abortion for this patient today? Is fetal surgery to treat this condition really happening in our area? Is it still experimental? As abortion bans and their medical exceptions change and Medicaid coverage becomes more restricted and complex in general, these shifts are reshaping where care is available and how it can be accessed. And more patients are encountering barriers regardless of the care pathway that they choose. And when you put all of this together, the problem becomes clear. Patients and providers are forced to navigate increasingly fragmented, complex, and rapidly changing information about what care is actually possible following a fetal diagnosis within a narrow, high-stakes decision window. This is leading to delayed referrals, insurance denials, missed specialty care, and gaps in counseling about how new rules affect patients. Without a way to track and translate these changes, these barriers become predictable. And they surface late in the perinatal window when the stakes are highest. And we hear this even from large, well-resourced centers with dedicated nurses and social workers who are the backbone of care coordination during this period, guiding both patients and care teams through referrals, insurance, and decisions about where and how care can be delivered, ensuring that clinical care reflects the realities of the system. And so our solution, the perinatal window, is co-designed with these nurses and social workers to strengthen care coordination across all settings by providing a centralized resource that helps clinicians understand care pathways across services, policies, and states, and translates them into real-time guidance for providers and their patients. Now let's imagine Lori's provider using the perinatal window to guide counseling and decision-making. So they start with the diagnosis, their location, and where Lori is in her pregnancy. And instead of searching across multiple resources, they can immediately see what is shaping care in this situation, including policy, coverage, access to services, and referral pathways. If Lori is considering ending the pregnancy, her provider can see what's allowed, where care is available, and can access short, targeted explanations from trusted experts who translate those policies into practice. If she's continuing the pregnancy and weighing prenatal intervention compared to postnatal intervention, they can see what interventions are available, where they are offered, and what constraints apply. And critically, they can also understand the support systems around these care pathways, including travel, housing, and social services, which often determine whether a pathway is feasible. All of this brought together in one place and updated as conditions change. Our customers are health systems, fetal care centers, and clinical practices. With over 120,000 births and even more pregnancies affected each year, the scale of need is large and consistently occurring across health systems. Our tool is designed for any clinician or coordinator navigating care following a fetal diagnosis across both specialized centers and community settings. And we're building this with the nurses and social workers coordinating this care across the country who serve as co-designers and our initial users. In terms of our competitive space, there are strong resources related to clinical expertise, policy information, and patient support, but they exist separately and they speak to completely different audiences. So what's missing is a way to bring these together into a single usable view of what care is actually possible for a given patient. The perinatal window will be housed at Parity Lab, a virtual health services research and education hub at Penn Nursing focused on complex pregnancy care. The Innovation Accelerator funding will enable our team to build the core components of the perinatal window. And during this pilot phase, the tool will be free to co-designer users, allowing us to establish a functional, scalable proof of concept with real care teams. And over time, this becomes sustainable through institutional and industry partnerships, where health systems pay for access to the platform and organizations sponsor the development of content. Our team brings together nursing, social work, and health services research with direct experience in frontline fetal care coordination. And importantly, we also hold leadership roles within the Fetal Therapy Nurse Network and the Fetal Care Social Work Collaborative, giving us direct access to the co-designers and initial users. This is not just Lori's story. We've seen this in the news, from people unable to end a pregnancy in their home state to others forced to leave the state to continue a pregnancy and try to access life-saving care. This is unfortunately what happens when care cannot be coordinated to meet patients' needs in these moments. And this matters because every day pregnant people receive a diagnosis that changes everything. And what happens next depends not just on medicine, but on the system around them. The perinatal window makes that system visible. It equips providers with the information they need to understand what is actually possible and to guide patients through those decisions with clarity. This is about making care more coordinated, more transparent, and ultimately more equitable at one of the most critical moments in life. And we are happy to take your questions, and I'll invite my team members to come to the stage so that we can all provide answers.
Okay, so again, we have 4 minutes for questions by our judges.
I can go. I will admit this is a little bit of a to a man with a hammer. Everything looks like a nail. So I'm an attorney by trade, and I'm kind of going. There is. I did notice an attorney on there, and this is one of those areas that I'm going is you've got to interpret this really, really carefully, and if you get it wrong, how do you deal with it? Because the risk is so high. So talk me through both. Why did you think an attorney wouldn't be a good idea, or just wasn't part of the plan, or and what happens if something goes wrong?
Sure. Yeah. So while we don't have an attorney on the primary team, we came up with this idea of needing these targeted educational videos because we've had attorneys come to our conferences and come to some of our meetings and basically do this for us, but only in a snapshot, only in a moment. And they're very careful, of course, about what they say. They make it very clear what they can and cannot advise us on. So it's going to be more high-level things like that with a lot of transparency about what they really can't provide clear guidance on, because sometimes that is what people need, right? Is to say, this is actually sort of a gray area. You need to talk to your institution. So we will make sure that we're clear about those things.
Yeah, maybe similarly, how do you how will you keep up to date on all those sorts of issues, which are probably very nuanced across all 50 states, and then similarly, all the conditions that you also need to update? It seems like a very large exercise around keeping data updated with pretty high stakes. So I'm curious of that as well.
Yes, sir. So this is something that the Fetal Therapy Nurse Network does every day, essentially, is keep this information up to date at each of our centers because any of our patients could need to go anywhere in the country. So it is challenging information to keep up with, and that's why once we build this via sort of crowdsourcing and information together, the most important role will be the person maintaining it, will be the person who connects with, for example, the Society of Maternal Fetal Medicine has a tracker app to make sure that we keep track, and we've actually worked with them to have trackers for legislation that get introduced specifically about things that affect fetal conditions. So we are going to partner with other larger organizations to do some of that tracking work. Like you saw, we have folks that are doing the policy tracking, but it just doesn't necessarily get translated into what this means for clinical practice. So we'll be sourcing from there. But yes, we do need to invest in maintenance.
Thank you, Abigail and team, for that great presentation. I think similarly, just so I'm clear, is your data sources of pulling. So are you telling your software, your perinatal window, like where you're pulling the sources, and then there's an end user that's monitoring it and then kind of making it available? So like you have the technology pool, but then you have the clinician eye before it
yeah.
kind of, yeah, sorry, go.
Yes, no, exactly. We would have oversight of both essentially, and that's why we made sure that our team, represents people still working in a clinical space. I'm mostly research, but Barb and Kara both are working directly in clinical spaces. All of our initial users will be working directly there. So we will certainly have as much transparency about where the data come from and who has done the interpretation or, when the last time it was updated, all of those kinds of things.
Thank you.
Barb and Kara, anything you wanted to add to the questions I answered so far?
Conference this week, and the biggest discussion has been how challenging it is to have the burden of locating resources and finding resources that are outdated or inaccurate. So this really is very timely to be able to solve a big problem for those of us trying to provide good patient care.
Kara?
Yeah, to add to that, Kara, I think my husband, when we were first talking about this, my husband said, well, what about Google? And I'm like, Google gives you a million hits, and then you have to try and figure out what's good and what's useful information. This idea is it's vetted, it's a one-stop shop, it's the place where we know that the information has been, as a nurse coordinator, I don't have time to, I need to go someplace where I know the information is right there at the tip of my fingers. I can go there, I can say, okay, yeah, this is what I need, and then move on to my next patient. So this is, going to be a huge time saver for clinicians.
Thank you so much. And unfortunately, we have to move on, but I thank you for your presentation. And for our last pitch in the general track, I would like to invite Antonio Davila.
Hi. Hello? All right.
Hi.
Hope everybody can hear me. I can't really hear it, but all right. Well, thank you, everyone. Sepsis kills more Americans every year than breast cancer, prostate cancer, and AIDS combined. In most cases, we don't miss it because we don't treat it. We miss it because we don't see it early enough. I'm Antonio Davila. I'm a mitochondrial biologist working in trauma medicine here at Penn. I've been studying mitochondria for a long time in many different contexts. All of my training and experience has culminated in this, the mitochip, a new way of directly measuring the energetic health of immune cells at the moment when intervention can still change the outcome. In trauma and critical illness, sepsis doesn't appear suddenly. There is a progression. For patients that survive the first 24 hours following a traumatic injury, there is a high risk of developing dangerous secondary complications from hospital-acquired infections. And this is due to a compromised immune system. This can lead to sepsis, multi-organ failure, and death. This entire cascade unfolds silently at first. The tragedy is that by the time we diagnose sepsis clinically, the damage is already well underway. This gap, the misdiagnostic window, is where patients are lost. Sepsis remains a highly prevalent condition with a high morbidity and astronomical cost. An estimated 1.7 million adults in the US develop sepsis each year. About 20% of all deaths worldwide are due to sepsis complications. I was told that listing references isn't a normal thing for this kind of presentation, but I'm a scientist and I don't want to say anything that I can't back up, and this will be available at the end. Sepsis is predictable, but it's missed because we don't measure the root cause. Immune cells are energy-limited systems. Every immune cell function, chemotaxis, phagocytosis, cytokine production, everything needed to protect you depends on mitochondria-generated energy, ATP. After a trauma, mitochondrial energy production in immune cells degrades early. Critically, the loss of the mitochondrial membrane potential, the voltage, occurs before immune system failure and before sepsis is clinically apparent. And yet, in modern medicine, clinicians never measure immune cell energy. Instead, we rely on downstream non-specific markers like lactate, pH, and vitals, signals that tell us that damage has already occurred. Mitochip changes that. Mitochip measures what fails first in sepsis. Mitochip is a patented point-of-care platform that directly measures immune cell mitochondrial membrane potential from a fingerstick scale blood sample. It gives a direct readout of mitochondrial health, designed for rapid, repeatable use in real clinic workflows. Mitochip specifically measures mitochondrial health in leukocytes, immune cells, and not in other cell types, tissues, or markers. Manufactured at semiconductor scale, our silicone wafer-based fabrication enables low cost and reproducibility. This technology is lab validated and published. These are images from our peer-reviewed publications and patent. This is the research version of the chip. And you can see that it's hooked up externally to a multimeter and computer. The accelerator funding that we're asking for today will help us develop the commercial clinical version. With this device, for the first time, clinicians will be able to see immune collapse before it becomes irreversible. Mitochip isn't a single diagnostic. It's a scalable platform. It was conceived to be upscalable and integratable with microfluidics and other systems. It allows multiple measurements per slide and assay customization. What this means is longitudinal monitoring, therapy response tracking, and expansion beyond trauma into transplantation, oncology, infectious disease, and drug development. Should be noted that we are situated within the Silicon Valley biotech mega hub. Philly is the birthplace of cell and gene therapy. Mitochip is infrastructure for measuring cellular energy wherever it matters. We are creating a new diagnostic category with no direct competitors. Today, sepsis diagnostics depends on late indirect biomarkers, but immune mitochondrial function is not only measurable, it's clinically actionable. If a clinician knows early that immune cells are bioenergetically failing, then resuscitation strategies can change. immunomodulatory therapies can be timed correctly, and patients can be triaged before they crash. Sepsis causes 270,000 deaths in the US every year and costs nearly $40 billion. Despite that, there is currently no point-of-care device that directly measures immune cell mitochondrial health. MitoChip fills that void. Once adopted, MitoChip becomes embedded in laboratory and clinical workflows. MitoChip doesn't win by exclusion, it wins by entrenchment. It integrates easily into existing workflows, it generates data clinicians can publish and act on, and it builds switching costs through longitudinal data sets and validation. Once immune energy becomes visible, it becomes indispensable. MitoChip becomes a tool clinicians don't want to practice without. MitoChip sits at the intersection of trauma medicine, mitochondrial biology, and nanofabrication. And so does our team. This team wasn't assembled to build MitoChip. MitoChip emerged from us. We combined deep trauma and sepsis care, foundational mitochondrial biology, and proprietary device design. We didn't observe this problem from the outside. We encountered it while taking care of patients, and we built the solution ourselves. MitoChip changes sepsis care by measuring what actually fails first, immune cell energy. Earlier insight, better decisions, more lives saved. Thank you.
Thank you so much. And now over to the judges for 4 minutes of questions.
Antonio and team, thank you for this great presentation.
Thank you.
Do you and your team envision this point of care system at the bedside, say like the nurses obtaining samples like we do with glucometers or like AccuChecks? Is that how you would envision the implementation of this technology for like the user end?
Indeed. It's a standalone, fully functional device that can be integrated into the current systems. It is intended to be used at the bedside with a minimal amount of blood, and it could be used as often or as seldomly as needed. And because it is non-invasive, there's no need to have a blood draw or really do anything more than just a quick finger stick, and this will take about a minute to give an answer.
Thank you. And then easy transferability into a system like Epic, like for EHR?
Eventually,
not
yes.
there yet?
Not there yet. We're yeah. But
Thank
I
you.
envision that happening pretty quickly and pretty readily.
Is this sorry?
Oh, I was just wondering, since this is a new way of monitoring and diagnosing, how do you get this technology instituted into the standard of care so that this becomes like a first step or something that folks would do? And then who interprets the data to take the proper action? And how are they trained for that?
Right. Well, one of the most important things about this platform is that we use standard, repeatable metabolic assay formats, albeit at a very miniaturized scale. And so that makes these kinds of tests and assays really implementable into cell culture and R&D labs first. This is crucial because commercial research and cell industry applications precede clinical diagnostics. And so this will provide kind of early revenue and, more importantly, data accumulation before the regulatory timelines. So before the clinical diagnostics that will require extensive validation and trials, we will already have a body of data and user experience.
So is it fair to say that this is more in the proof of concept stage and the technology, the concept itself is still being validated, or is that science itself solid and we don't have to like evaluate that right now?
Well, the technology is sound and validated and patented. So the chip works and it does what we say it does. I'm glad you brought this up. I am currently the PI on a clinical research study here at Penn Presbyterian at the Trauma Center. And this study is seeking to establish mitochondrial membrane potential as an early biomarker for sepsis. So the clinical research is ongoing, although there is much evidence to support this hypothesis, and that's why we're following it. And this is actually even, this also adds sort of in-place infrastructure to validate this clinically in parallel with a clinical trial that is ongoing currently.
And can you talk through the timeline of a typical progression and sort of how much time does this intend to save and how that impacts treatment?
At the patient level, you mean?
Yes.
Well, there is no comparable technology available now. Clinicians, when in a special trauma situation or in any situation, get labs back. That is, they draw blood, they send it off to the stat lab where they will analyze it for CBCs and blood gases and all the vitals. And so that can take time. That takes time for it to come back. And that is done generally at very defined instances. So when the patient in trauma, for example, when the patient arrives at the trauma bay, blood is drawn, labs are done. But then they don't keep coming. You have to, usually you wait a while before you have more blood drawn and labs done. Our technology is a bedside device that is non-invasive, and this could be used anytime, as often as possible, on a drop of blood. So this is non-invasive. It won't interfere with normal sort of health worker rounds, and it won't impact the patient nearly as much as having blood drawn, which usually to do this kind of work in a laboratory, for example, this takes about 5 milliliters of blood to have enough cells to do this work. Our very sensitive voltage sensor can do this in 80 microliters. That's about a 10,000-fold smaller scale of sample necessary. So the short answer is this isn't possible any other way, and we're here to revolutionize care.
Okay. I think we're running out of time, but thank you for this presentation, Antonio. I want to thank all our finalists for their inspiring innovation ideas and pitches. They all put so much work into their presentations, and it really showed. Now, judges, if you will please exit this main room, head over to the Zoom breakout room to begin your review of the pitches. And just as a reminder, you will need to use the separate Zoom link. Thank you. And now I would like to introduce our keynote speaker, Dr. Anthony Esposito. Dr. Anthony Esposito is the Chief Nursing Officer at St. Joseph Hospital in Bethpage, New York, and he provides executive leadership across nursing practice, quality, and patient experience. He's an adjunct professor and a Johnson & Johnson Nurse Innovation Fellowship alum from the 24-25 cohort. And Dr. Esposito is passionate about advancing nurse-led innovation and empowering nurses to translate frontline insights into meaningful impact. So, Dr. Esposito, I'll turn it over to you.
Thank you so much. I appreciate it. And what amazing pitches from everybody. You should all be extremely proud of the work that you've done. And I'm going to share my screen really quickly, and it looks like it is working, which is fantastic. But as mentioned, I'm the CNO of St. Joe's here in Bethpage, Long Island. I was told it's smart when talking to a crowd in Philadelphia to let them know that my son is a big Eagles fan. Although I'm a sad Jets fan. He has magically grown up to be an Eagles fan, so he likes teams that win, which is good. Just wanted to mention that I don't have any obligations, endorsements with any of the photos or images or companies that I will speak about today. So going to make sure this works. Here we go. Innovation, I believe, has somehow found its way to have many definitions. And I want to talk about a unique one today. I believe that innovation is invention times commercialization. And what does this mean? This means that the invention part is an idea or a substance or something technical that adds value to something or someone. So perhaps this makes something better, or it makes something faster. That's what the invention piece is. The commercialization piece is getting that invention to the users, the public, the people that it matters to, that can actually make something faster or do something better. And it's very scripted that we use a multiplication sign here, because if you have a 0 at one of these locations, you get a 0 for the totality of it, right? So if you have a great idea, great invention, and you multiply it by having no way to reach your public, you don't have something of value, right? The same way if you have something that you can get to a lot of people, but it has no impact on their lives, you don't have innovation. So it's not a plus sign, it's a multiplication sign. And that's what our definition of innovation is here today that we're going to talk a little bit about. So I'm going to start by talking about the project that I did with the Johnson & Johnson and UPenn Wharton Nurse Innovation Fellowship, because it's a different direction than some of the other things we're going to talk about, but it was fun, unique, and it talked a little to the human-centered design, which is so important in what we do to define the problems we want to solve for in innovation. So it was my co-founder and myself, Dr. Kimberly Ross, came up with the Right Now Mentor. It's an AI-generated app that helps our frontline leaders to handle different situations that they might come across where there's not somebody for them to mentor them in real time. So there's a home screen, sign-in screen, similar to a chatbot style, maybe ChatGPT AI function. You can ask it anything that you like. You hit submit, you get a response. We use the example of what is an FTE. Gives you a response, it gives you resources, it gives you also an in-house expert. So some of this is pulled from pretty much the World Wide Web, and then the other stuff is things that we have uploaded for it to pull from. And you can do this at any location or institution. There's a way to rate the response, which is very important, so that way we eliminate garbage. Garbage in, garbage out is obviously very important here. We don't want to keep getting the wrong answer on something. We know AI can be wrong about 11% of the time. And then there's a kind of a backstage situation where you can run reports, look at search histories, and see what your people are doing. So if you have a certain nurse manager, let's say, that keeps asking the same question, as a supervisor, you can run a report and say, okay, Anthony keeps asking about FTEs. I better get him some help with our experts. So that way he doesn't have to keep going to the app to learn what he's looking for. So with that said, innovation is a journey. And I love this picture because it's not just a winding path. It's a path that shows incline, decline, setbacks going backwards, and of course, advancements. And that's really what this is. I do something called a think tank, which we'll talk about later. And we get a lot of people that will come to us thinking they have a solution for a problem they have not yet truly figured out. And that's some of those setbacks. You want to make sure you use design thinking, human-centered design, whichever you want to take as your path, but have a good structure to determine what the problem you're trying to solve is. That way it eliminates some of those uphill parts of your journey or those setbacks that are going to come in your journey. But there is no straight journey in this. And truly, that's what makes it fun and helps you to learn along the way. So this is one of my favorite stories to talk about. Innovation is not just in Silicon Valley, it's everywhere. And for those of you nurses that are here listening, Lumify is a great story. It's a light, it's a wearable light, and this is the 2.0 version. It started just with Lumify. And it's essentially a magnetized flashlight that you could wear on scrubs, shirt, any material. And it came from the innovation of two nurses that were working at night and continually fumbling with some sort of light source. And this was their innovation, and it really took off. They have both since retired from technical nursing and run Lumify and sell these wearable flashlights. This did not come out of some tech mobile in Silicon Valley. It came out of them working in the hospital, dealing with an issue that they were fighting every single night, and they wanted to fix it for themselves and for everybody else that had to deal with it. So really fantastic story. And I've actually had the pleasure of meeting one of the founders of Lumify, and when they talk about the problems that they were dealing with and living through it, and that's how they come up with the solution, feeds back into figuring out exactly and getting very granular with what the problem is you're trying to solve for when you're looking to innovate. It's very important, and a shout out to them and the great work that they're doing with these wearable devices, and they continue to innovate and change a product that was good, and they're looking for great. So St. Joseph Hospital is a small community hospital on Long Island. We are about 203 beds here. We run a little short of that at our capacity. We have one of the busiest emergency rooms in the entire Long Island, and we are actually the busiest semi-center for all of Nassau County on Long Island. So we are very, very busy. Our cath lab turns over a lot of patients, and we save a lot of lives in our community. So what do we do here for innovation? We're a small place. We do not make money. And so how do we look to innovate? So came up with 3 of my favorites that we've done just in the past year. To talk about the first one, engagement. This is really a low to zero cost way to attack a new and innovative way to get your staff engaged. We sat down as an executive team first, and we said, we're going to lay out a calendar, and we're going to fill this calendar up with engagement events that we've never done here. And so first, we all put down a couple of things we'd be interested in. Then we took to our leadership teams, we brought back feedback, and we said, okay, what can we do? What can't we do? What might we have to table when we have maybe more resources or more time to figure this out? And what can we put into our calendar? We loaded that into the calendar. Then we did multiple pop-up days for our staff for them to come and tell us what type of engagement events they would want to see from the hospital. We got some fantastic ideas, and we ended up having a calendar filled with about 51 different events throughout the year to engage our staff. That ranked from everything from free French fry day to free coffee day to having puppies come in that could be adopted to meet with staff. It was really amazing, and we're just a couple of months shy of completing this, which really lined up well with our engagement survey, so we can see how we did one year to the other. Just to give you an idea, the year previously we had about 9 engagement events, so about a 5-fold there on our events. And we didn't use AI, there was no robots involved, low cost, low drag strategy to boost engagement. The think tank, this is one of my favorites. So after I completed the Johnson & Johnson Nurse Innovation Fellowship with UPenn and Wharton, I wanted to bring back this innovative mindset to my system. And I tried to do some sort of standalone situation with this, and it really was not successful. So I pivoted and I said, okay, what do I already have in place that has structure and it has clout with our C-suite to get things done? And I found that our nursing shared governance structure was a really great place to implement innovation. So we started a council through that shared governance committee called the Nursing Innovation and Technology Council. Of course, I facilitated that council, and we had representatives from all the hospitals. We have 6 hospitals in our system that came and really started the council. The big thing, though, that came out of this was we started our think tank. So what we did for our first year, we're going into our second year, is that we host a think tank at each of our sites. So we hold 6 think tanks where there was a very, very short application process for any staff that worked at the hospital to come give a 2 to 5 minute presentation on an idea or a pitch, similar to you guys just did, on what they think we could do to fix a problem. Tell us what the problem was, tell us what their grand idea was. And man, you get some of the darndest things, and we really did not put a filter on it. We wanted to hear everything. As long as it was appropriate to be spoke about at the hospital, we let it go. We had an average of about 15 to 20 ideas come to us during the event. We also set up space for an audience. So we had tons of members of all the teams that were in the hospitals listening to these pitch ideas. Hopefully that opens up those pathways where people start thinking, hey, you know, when this comes back next year, I want to get involved, or I want to talk about this, I want to pitch this. We're very happy to say that we were able to implement 1 to 2 ideas from each site that were implemented in either a micro or macro phase. So we had some ideas that we were able to implement or pilot on maybe a certain unit, and we had other ones that we were able to pilot at an entire hospital. But really fantastic event. It's a lot of fun. We do a lot of PR to drum up excitement around it before we do it. And I have to say, it's been greeted with welcomed arms at all levels, including our executive C-suite for the system. This is something they've now come to look forward to, and they ask about for our next year. We'll be going and starting our next round of these in just about 2 months. So really excited to get that kicked off again. And some really great ideas have come out of it. And I will say that one of our limiting factors, everybody has limiting factors when they're coming up with innovations, is a budget, right? We don't have tons of money to dump into some of the ideas. And some of the ideas that we put in the parking lot, when we do come across the ability to fund some of them, I think could be fantastic. And that was one of the only limiting factors to putting those forward. But we're keeping them ready in the wings for when we get a grant or similar to move forward with those ideas, which I believe could go system-wide very easily. And the last one, our summer 4-day work week. So a couple of years ago, we had struggled with our HCAHPS in this hospital, and we were one of the bottom of the barrel in terms of how we ranked against our sister hospitals in the system. And so, along with some other ideas, innovations, and changes, we told our management team that if they were able to hit the thresholds that we wanted at a 3-month or more consistency for their HCAHPS scores during the summer, we would give them a 4-day work week. They had to maintain those scores through the summer. And so we had 3 out of our 4 inpatient areas, our entire ED, and our PACU area in the peri-op suite be able to have a 4-day work week for our management staff. And I just heard a couple of pitches that talked about burnout, and one specifically about our nurse leaders. And man, I've never seen a happier group during the summer than those groups that earned that 4-day work week. And let me tell you, the groups that didn't, they are working tirelessly to make sure they get there. But fantastic way to just innovate and change up something that is the monotony of our day-to-day, our 5-day work week, right? We know we have a little less surgery going on. We have a little less volume in the ED. This is a safe time to go ahead and explore a 4-day work week. And I will tell you that it has not shown any negatives thus far with us implementing this. And I'm excited to look towards our 2nd year, which will be starting very soon. So an approach alone can be innovative. Again, we don't need robots and AI to make something innovative. On the right, we have Coach Bill Belichick from the Patriots. Not my favorite coach, but man, did he win a lot of Super Bowls. And something he was famed for was telling his staff not to come to him with what his team could not do, right? So don't tell me what Julian Edelman cannot do. Tell me what he can do to help me win the game so that I can use them how I see them fit into this scheme. Something that was kind of revolutionary at that time, and something that proved to be a real positive in them being able to win the Super Bowls that they did. And like kindness to that, we have leading with kindness. Something that even just many years ago was not something that was looked at as a form of leadership. And now we have multiple books, but Dr. Baker, one of the most famous books, in my opinion, about leading with kindness. And this has taken on a whole new role. You have people like Simon Sinek talking about this at his TED Talks. This has taken on a huge quantum leap forward for our leadership models, and something that just even a couple of years ago, people that were historically in leadership would have thought this not to be something of importance in leadership. So just something as simple as a different style of approach can be innovative. Now, we have other types of innovation. And when I ask you, what does innovation look like? Just take a second to think about what that might be. And I think a lot of us probably move towards the tech industry, but just take a second. Think in your head, what does innovation look like to me? What's big innovation? So I hope you have something in your head. And I will tell you, growing up, this is how I watched movies. I had a VCR, and I popped the cassette in there, and that's how I watched my movies. I will tell you that my 2 sons now are growing up, and they know how to work Netflix on my smart TV. Now, I would never have guessed this growing up. And I will tell you, my parents definitely would have laughed at me if I told them that's how my kids would be watching movies. But that is innovation in this sector, right? In this industry. Cars is another big one. On the left, no joke, as the car I grew up learning on. I had an old Civic that was given to me with hundreds of thousands of miles on it. And it was a manual. And I ended up learning how to fix cars because of that car, because it broke down a lot. It was an ICE or internal combustion engine car. something that was the only thing you could get at that time. And now I have a father-in-law that drives a Cybertruck. It is obviously not only automatic, but it has a motor, not an engine. It's completely electric. This is what my kids are going to see and grow up knowing. They have an option for it to be completely driving itself. Again, something that we would have asked some of our parents, they probably would have laughed at us, but that's what innovation looks like in the automobile industry. And really, I mean, look at those two vehicles. What a stark difference from the late 90s, 2000s, and into today, what you could be driving and what that driving experience has become. This is probably the most relevant in everybody's life. I'm sure if we all tap our pockets right now, we have a phone in them, and it's not just a phone anymore. They're smart devices. They do a whole lot more than just make calls or send out text messages. And yet our parents, or even back to our grandparents, they were using the telephone on the left, and it was mounted to a wall. And that was, you had to stand there and make a call. And if it was a long call, man, you'd be standing there for a long time. And now we have the world at our fingertips, sitting in our pocket at all times. Sometimes it's like this bad temptation, right? But man, that's what our kids will be growing up, and that's what they'll be knowing as a phone. And that's what that innovation looks like in that sector. And so it doesn't necessarily have to come from these grand, giant ideas of making a house phone turn into a mobile device that can reach, any network in the world from our pockets. Post-its were an innovation at one time, right? We're talking about sticky paper, everybody. Sticky paper. Amazing, right? We use it every day. I have them on my desk as we speak. But that was innovation. Velcro, something that we see all around us. Innovation at one point, right? This is two pieces of material that just stick to each other. I mean, wow, mind blowing, right? Paper clips. This is a bent piece of metal. Again, on my desk every day. I'm sure many of us get papers handed to us every day with a paper clip. And yet this was an innovation at some point. And so I don't want anybody to fall into that trap of I need AI, I need robots, and I need technology for something to be innovation. Innovation takes many forms. And these are some of my favorite examples, especially Post-it. Still blows my mind that sticky paper has made somebody a lot of money, and I did not think of it. But innovation is something that has to be built into our DNA, because when we fail to innovate, we can lose everything. And these are some of the four, in my opinion, most famous companies that failed to innovate, and they lost everything. Blockbuster failed to innovate by moving away from the physical, if you will, form of film and watching movies. They failed. Toys R Us, they remained trying to be a big box store and mortar and brick style of sales, and they did not make it. Nokia failed to innovate and match the technology that was being put out by Apple, and they didn't make it. MySpace got taken over in a big way by some of its competitors like Facebook, Instagram, Twitter, you name it. MySpace is not even a thought in people's social medias anymore. Yet at one time, these were the big names in their industries. So innovation has to always be at the forefront of what we're doing. And it relates back to that flashlight I just showed you, because that was the 2.0 model. You can't just sleep on the 1.0 or that first model. We have to continue to push and innovate, because when we don't, everybody else is doing it around us, and we are just falling behind. So it's important to read the room when we're looking to innovate. And I spoke a little bit about identifying the problem before, and you could have catastrophe when you don't read the room and find out what that problem is and go to the sources to figure out exactly what you're solving for. I think one of the most famous ones, if anybody remembers when MP3s first came out, was the Zune. So you had Apple with the iPod, and then its biggest competitor at that time was the Zune. And it really failed to compare in almost every way to what the iPod did. And it came up with this innovation that wasn't what the people wanted. So it was interesting because there was things that the Zune did better technically. It had a colored screen before the Apple iPod did. It had the ability to hold more songs than the standard iPod, and yet people still wanted the iPod. Much of that was because ease of use. That's really what it had come down to when you look back. But it's pretty amazing that you could think you have a better product and yet people will still use something else because you didn't do enough research, reading the room and figuring out what the issue you were solving for is. One of my favorites, because I really do love electric scooters, and yes, of course, I wear my helmet, is Segway. So Segway, their first production into the electronic transportation space was the scooter on the left here. And that was their Segway scooter. It was this large two-wheeled device that you had to stand on top of. And it was a leaning style gyroscopic mechanism. So you lean forward, it went forward. You lean back, it went back. And it was a lot of what they thought the problem was. It was an electronic forms of transportation, and it wasn't using gas. It was smaller than a car, and it was much cheaper than a car. And it was a total flop, complete flop. It was blown out of the water by electric scooters. Now, Segway saved themselves because they reacted quickly enough to the market, and now they are known majority for their electric scooters. But they used that same technology, they pivoted, and they remained relevant, and later on, actually one of the most successful scooter companies, but had a huge flop in the beginning because they didn't realize that being able to maneuver, lift, and carry the device they were building was a huge part of the problem. So they came up with what they thought the solution was, and they missed the mark completely because people couldn't transport their device the way a scooter could be transported. So very important that you do your research and you make sure you understand the problem you're solving for. So this is the diffusion of innovation theory. We're going to talk a little bit about it. We're not going to get too into the weeds, but there's a couple of things here I just want to talk about that I think is very important to understand about innovation. So this is what you might consider a typical bell curve. And on the left, of course, you have your innovators. So that's your 2.5% of people that are big idea. This is the next big thing. Listen to my idea. This is what I want to do, right? And we all know those people, and hopefully you are those people. Then you have the next group, which is in the blue, which is that 13.5% of early adapters, right? The early adopters that say, hey, great idea. I'm in. I will help you. I will use it. I'll talk it up. They're in on it. Now, there's a chasm here that happens after that group. And this is where most big ideas or innovative ideas, unfortunately, go to die. And it's before they can even reach the early majority phase. Now, that chasm comes in a multitude of different reasons. It could be, like I said before, there's no budget for it, it dies, and nobody goes and tries to figure out a unique way to get funding. It might be time. A lot of people like to blame time, and I could get on a whole soapbox about that, but if I have an idea and I say I don't have enough time, things fall off in that chasm. Right? And I'm sure we could all think of an idea we had, a project we wanted to do, or something else that we thought was a good idea, and it went to die in the chasm. And I can think of at least two probably right now, actually. But we all know it. And just to continue through, obviously you have your early majority, your late majority, and your laggards. And if you were able to bridge that chasm, this is what that diffusion of innovation looks like. This is where people are getting involved. And it's so important to make sure you reach that large majority in the middle and are able to circumvent that chasm at whichever means necessary. And today, actually, during some of the breakout sessions, I had such a wonderful question asked to me, and they asked exactly what we're talking about. So what do I do if I don't get funding at an event like this? How do I continue to move forward? And I said to them, there's, in my opinion, there's three really big ones. There's a lot of other ways to get money and funding, but there's three big ones. You can bootstrap it, so you pay for it yourself, right? And that's typically really hard to do. You can look for events like this, and just by doing searches, you can find a lot of events where you can have an opportunity to pitch your idea and have some opportunity to make money and funding for your project. Another part that I think kind of falls in that same category is looking for grants. There are so many great grants out there that people don't even know about. And I've been a part of a few and found out that there's really not always a lot of people that apply for those grants. So do your research and look at how you can find grants, apply for grants, find these types of pitch events, and be able to get involved and pitch your ideas. And then finally, the last one is utilizing your networks. We're blessed and cursed to live in this world of social media. But one of the great things about it is that we have an opportunity to reach so many people. And by getting involved in social media, reaching out to people that maybe are doing things in that space, might even be a competitor in that space, asking them to talk and listen to your idea, or maybe get involved in your idea, partner up with your idea. Maybe they'll even fund your idea, is a great way to also possibly find resources. There's the Instagram touts itself of if you start your very first Instagram account and you have 0 friends, 0 followers, you have nothing going on, you do one post, it guarantees 2 people will see your post every day if you post it every day. So even if you started an account, got your information out there once a day for a month, you would reach 60 like-minded people that would have an opportunity to possibly help you with what you're working on. So those are the 3 best and biggest ways, in my opinion. There are a lot of others, some a little more dynamic, but those are the 3 best ways to bridge a funding gap, like was asked to me this morning. And it's usually the most common issue, honestly, that comes up in terms of innovation. I think it's very important, and one of our I think it was the first group, I want to say, that was pitching, spoke about looking at other industries. And it is so important to look at other industries because we can learn from them and they can learn from us. This is a list of the 50 most innovative companies of 2025. And you look here and it's very interesting because the top 5 really have nothing to do with healthcare, which makes me sad, but we will get there. But you look across the list, not a ton of healthcare in there. So you can pick any of these companies, do some research, go online, find out what they're doing, what they do well, maybe what they're trying to do better, and pull from those ideas. I really love cars, and it's something that I have a passion for. And I always love to talk about Toyota with their high reliability models, because at one point, high reliabilities modeling or high reliability organizations in any industry was innovative. And now we're all trying to do it. And Toyota was one of the first. And I will tell you, I drive a Toyota because how reliable that thing is. But we can look at any of these and see that. You have General Motors, Ford, more automobile, right? Mitsubishi does some other things, but they do have automobile. You can look at all of them, compare, contrast, find out what one's doing that you like better than the other. How do you apply it to medicine or healthcare? It's a great way to innovate. So I played lacrosse essentially my whole life. I played into college as well. And this is a picture actually of my buddy, Brian Luzzy, who plays for Cornell right now. He's somebody that I coached when he was a little bit younger. And there's a rule in lacrosse. We call it the 20% rule in lacrosse. And it's that you only score 20% of your shots you take, right? And I learned that the hard way when I was a lot younger because I was not shooting enough. And I had a coach tell me about this rule. And it always stuck with me. And I teach it now to my kids. I coach their lacrosse and I teach it every day. We got to take shots because you're only going to make 20% of the shots that you're even going to take. So in innovation, we have a 10% rule. And the 10% rule is that you are not innovating enough if you're not failing 10% of the time. And so what do I mean by that? I'm not saying that you should try different forms of surgery that's evidence-based and possibly hurting 10% of your patients. That is not what I'm saying here. I'm saying that there are safe and reasonable things that we can come up with in an innovative way that is not going to affect our patients and could have really profound effects on things like I spoke about before, engagement, right? Or patient experience. And we should be trying those things and not afraid to fail at that 10% rate. And I would ask all of you, do you think you are working in a place where you have the ability to fail 10% of the time? And it kind of sounds like a lot when you think about it. I will tell you that here in this hospital, we did not have that when I got here. And it really was not until I went through the program and learned a lot more about innovation, what it means, how to innovate, and how to rebound from failure. Until I really started finding the ability to give my team that psychological safety to fail 10% of the time. And for a lot of you here that are leaders, and we spoke about this in another breakout session, as leaders, our job is to make sure we give people the space to fail at that 10% rate. And they have to have the psychological safety, as I mentioned before, to be able to fail and come to you and say, hey, listen, I tried this, it didn't work, and I want to pivot and try this instead. And for us all to be there and say, great, let's do it. What did you learn? How are we going to make sure that mistake doesn't happen again? And how is this a better idea? And challenge them to do better with the next one. But make sure you're doing that every day and try and get to that 10% rule to allow your teams to be innovative enough and find the next big thing that's going to come to us in healthcare at a pitch event or somewhere else. I know I am standing between all of you and finding out who is going to win this amazing event. So I would love for any of you that have questions, ideas, anything you'd like to run by me. I do have my email here up on the screen. Feel free to write it down and reach out to me. I'd be happy to chat at any time. George, I want to say thank you so much again for having me. It was truly a pleasure and a form of homecoming for me in many ways. And I'd love to give it back to you right now.
Thank you so much. Thank you for that wonderful, inspiring talk. It was also great to see you showcase Lumify, which one of the team members started with our Innovation Accelerator as well. So it gives hope, I think, to all of us to know that great ideas can start with a pitch presentation at an event like this. So thank you again so much. Now I would like to recap our 5 presentations using the sketches that were created by Rachel Acker from Health Hero. Let's see if Rachel can actually join us on the stage. Wonderful. So as you may recall, we had the Ready to Practice track and Ellen Winkle. The next one was Florence Vanek and Annalise Wood for Core Insight. In the general track, we had Tammy Doyle, Abigail Wilpers, and Antonio Davila. Thank you so much for capturing the essence of all these presentations. And I want to say that all our presenters have done a great job, and I want to congratulate them all regardless of whether they get awarded today or not. And I think it's really important to see them continue this work, and obviously the Penn Nursing community is here to help. And now I would like to call Bruce Derringer, one of our judges, who will announce the winners.
Okay, George, do you see me? Am I on?
Yes, I see you.
Okay, great. Well, congratulations again to everyone. The effort and work that everyone did for the presentations really showed. So really a great effort across everyone. Unfortunately, well, not unfortunately, we've have decisions that were fairly consistent across all the judges, which made our discussion a bit easier. So in the Ready to Practice track, we awarded both teams the award. So thought both did an excellent job. So Ellen as well as Florence and Annalise. So congratulations to both teams there. I feel like there should be like a audience applause or something, but we'll insert some fake applause. In terms of the general track, we also had as I said, a very consistent view, and we decided to award Antonio Davia. So congratulations, Antonio.
Well, that's wonderful. Congratulations to winners for both the Ready to Practice track and the general track. Before we close, I would like to thank everyone who participated today and made this event possible, including our Dean, Tony Villarreal, Maya Greenspan, Anthony Augie, Dr. Neetu Singh from the Penn Center for Innovation, our Innovation Board of Advisors, several of them helped with the pitch practice sessions, my colleagues at Penn Nursing and Penn Medicine, and of course, all our speakers and the judges who spent time reviewing and judging and looking into these applications. It definitely takes a village for this type of competition, so I want to really thank sincerely everybody who participated. I would also like to thank again the Bedford Falls Foundation for their lead support of the Penn Nursing Innovation Accelerator, as well as Carolyn and Thomas Bennett and Andrea Laporte and the Penn Health Tech team. And obviously our participants for sharing their innovations with them today. And I hope these presentations inspire more nurses to begin creating solutions to these problems they face in their own practice. So thank you, everybody, and have a good night.